We have some exciting news here recently with the FDA approval of the first PSMA-targeted PET Gallium Scan for prostate cancer. Today we'll be getting to chat with one of the primary investigators who was instrumental in helping bring this new technology forward to get it approved for its initial use here in the U.S. Listen in to learn more about this new technology. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pullman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. I'm very happy to be able to introduce Dr. Rob Reiter, who is joining us today on the Prostate Health Podcast. He is the Bing Professor of Urology and Molecular Biology and Director of the Prostate Cancer Treatment and Research Program at the David Geffen School of Medicine at the University of California, Los Angeles. He is currently the Principal Investigator of UCLA's SPORE, or Specialized Program in Research Excellence Program, a $12 million research grant from the National Cancer Institute to develop new diagnostic and treatment options for men with prostate cancer. Dr. Reiter's clinical interests include robotic surgical management of prostate cancer and the use of both MRI and molecular imaging tools to manage this disease. He attended Stanford Medical School, completed his urologic training at Stanford and Baylor College of Medicine, and completed additional fellowship training in urologic cancer at the National Cancer Institute. Dr. Reiter, welcome to the Prostate Health Podcast.
Thanks for having me.
We have some exciting news to share with our podcast listeners. The FDA has approved the first PSMA-targeted PET Gallium Scan for prostate cancer. Dr. Reiter has been a true visionary in utilizing advanced imaging in helping patients address difficult management decisions. He was instrumental and one of the primary investigators for this new technology and bringing it forward to get approved for its initial use here in the USA. Now, before we get into the details about this exciting news for our listeners, I thought we could just take a step back and review, some of the basics about imaging in prostate cancer. So do you think you'd be able to provide with just a brief overview of what some of the various different tests or imaging tests we've utilized over the years for prostate cancer?
Sure, absolutely. I think we can divide the tests probably into two types: those that image the prostate itself and the cancer in the prostate, and then those that image disease that's outside of the prostate in regional lymph nodes or lymph nodes in the abdomen or retroperitoneum, lungs, and bone. So starting with imaging of the prostate, about 25, maybe 30 years ago, we started using ultrasound to image the prostate. And it's very good for localizing where the prostate is, but basically hasn't been really great for actually imaging the cancer itself. So historically, we would do ultrasound biopsies that use the ultrasound really just to guide where the needle went. There are some new technologies, new ultrasound technologies with much, much higher resolution that are showing some promise for actually imaging the prostate itself and could be used potentially in conjunction with some of the newer imaging modalities. I think the most exciting thing that's really come to the forefront over the last now almost 15 to 20 years is the use of MRI for imaging prostate cancer. So MRI has exquisite sensitivity. That means it's able to detect most prostate cancers that are of significance, which are the ones that we actually want to diagnose, so-called Gleason 7 or higher cancers. So MRI can detect as many as 80% of them. And not only that, it can really give you, we as physicians and urologists, a sense of where in the prostate is it located, is it escaping the prostate, and this can be used for surgical planning and management. And this is work that I've been doing with our group here for almost 16 years. So I think MRI has really revolutionized how we diagnose prostate cancer. We can do so-called targeted biopsies where we can actually put the needle into what we see as abnormal and get much better sampling and make much better patient decisions. Then in terms of imaging, but MRI is not very useful for imaging disease in lymph nodes or disease in bone. It's okay, but not great. So we've historically used two types of scans. Bone scans, which basically image changes in the bone metabolism. So if you have a prostate cancer in the bone, what happens is that the cancer causes the bone to lay down new bone, and you get so-called osteoblastic metastases, but you can also get destruction of bone or osteolytic metastases. And these changes in bone can be imaged with traditional technetium bone scans. The problem with them is that they're very insensitive. So until a tumor is pretty good size, you're unlikely to see anything. So most patients that we urologists see are patients with early stage prostate cancer and even locally advanced prostate cancer. The bone scans will be negative, but unfortunately that doesn't mean that the patient does not actually have spread of the cancer to their bones. The same thing is true with CAT scans, which have been used to actually look at lymph nodes and lung and soft tissues. They also can detect things when they get quite large, but are very insensitive and also are not what we call specific. That means if you see a lesion, you don't know that it's cancer, you would have to biopsy it. So that's really where the new molecular imaging technique that we're going to talk about today really comes to the fore in terms of increasing our ability to sensitively detect a location of disease outside of the prostate.
Well, thank you for that excellent review. And so back to the new FDA approval of the first PSMA-targeted PET Gallium Scan for prostate cancer. Can you tell our listeners a bit about this newly approved agent?
Absolutely. So PSMA, I think it's best to explain kind of what PSMA is in the first place. So it stands for prostate-specific membrane antigen. And it's basically a protein or receptor that's present on the surface of prostate cancer cells. And for the most part, it's not present in other normal tissues. So it's quite specific for prostate cancer. Most, but not all prostate cancers express or make this protein PSMA. And so the concept is if you can develop a small molecule or an antibody that will bind to this, and then you attach that probe, so-called probe or tracer, to a radioisotope that can be imaged with positron emission tomography or PET scan, then you actually can visualize it. So PSMA PET scans are essentially small molecules that have been developed to bind to PSMA on the surface of prostate cancers and then can be detected by a PET scan. And the radioisotope that is currently being used the most is called gallium. It's a positron emitter, but there are other positron emitters. One is F18, and there are newer PSMA tests and probes that actually use that radioisotope, which actually may make it easier and more available around the United States.
And how is the drug administered prior to the testing?
So the test is about a 2-hour test. Patient comes in, there's some preparation that the nuclear medicine folks will give to them. And then basically an IV is placed and the tracer is administered through the IV. You have to wait usually about 30 to 60 minutes, I believe, until the tracer basically circulates around the body. And then basically you undergo a PET scan and a CAT scan together so that you have a correlation between the location of a signal that you see on the PET scan with where it is actually in the body on the CT scan. So it's a PET, what we call PET CT scan. And it's kind of cool that now we're actually developing PET MRI scanners as well. They're still very few and very expensive. That's going to be the next iteration of this type of imaging.
Well, certainly exciting. Now, in what situations is it currently approved for in helping men with prostate cancer?
So we went to the FDA, and I would say around the world, in Europe, Australia, and other places where this has actually been in use now for some number of years compared to the United States. It's used in two major settings. The first setting is in patients who have had surgery or radiation and have recurrence of their disease, usually manifested by a rising PSA after they've had surgery for the most part, or radiation. And so it's used to localize the site of disease in patients whose PSA is rising. And the reason that that's important is because when we see men whose PSA is rising after surgery, for example, we don't know really the best form of treatment. Radiation has historically and continues to be an important what we call salvage or adjunctive therapy to surgery in patients whose PSA starts rising. But probably in about 50% of men, the disease is not located where we're actually giving radiation. And even when the disease is reasonably close to the prostate, it could be in areas just beyond the reach of standard radiation. So the concept is pretty simple. If you can see it, you can treat it. And maybe we can do a better job and be more selective and reduce toxicity of treatments if we can really guide the therapy to where the cancer is located.
Well, and you kind of somewhat answered my follow-up question to that in a bit, in terms of what are the advantages of this technology compared to current imaging options.
So there are a number of advantages, but I'll come back to the other point first, which is that not only can it be used in the setting of recurrent disease, but it can also be used in the setting of newly diagnosed disease. So particularly those who have a high-risk cancer and have a significant likelihood of having disease outside of the prostate, it can be very useful in those patients too. The advantages of PSMA over other agents, the major one, there are two basically. Number one, it's more sensitive, so it can detect disease earlier when the tumors are smaller. Number two, it's very specific, so there are relatively few what we call false positives. So if you see a lesion, it's likely to be real. And that's been confirmed by many studies where we've actually taken biopsies from the sites that are seen on the PSMA scan and confirmed them to be actually cancer. So those are the two major advantages compared to older forms of PET scans like FDG, which is sugar, or choline, which have been used for many years but are far less sensitive, or another test that's already approved and available called Axumin, which is another PET tracer, which is very good compared to historic tracers that we have, but it's also less sensitive than PSMA.
Yeah. So what locations in the U.S. currently have approval to offer this PSMA PET scan?
So right now it's very limited. Basically, UC San Francisco and UCLA, where I am, we joined together a number of years ago, about 4 years ago, to conduct a prospective study with the endpoint of getting this approved by the FDA. So we together went to the FDA about a year ago, and it was recently approved for use at UCLA and UCSF. However, and so right now it's really only FDA approved, available at those centers. But there are other forms of PSMA tracers that are being studied. So there are many clinical trials ongoing around the country. And there's another tracer that's already completed all of the necessary clinical trials. It's called PYL, which is just another small molecule that binds to PSMA. And I know that they have, I believe, already submitted for approval by the FDA. And so hopefully there will be a tracer very similar to what we currently use that will be more widely available within the next, year or two.
Yeah, well, we certainly look forward to that. And now, is the PSMA PET scan currently covered by Medicare and private insurance companies?
So it's a little complicated right now because it was just approved by the FDA. So Medicare has not yet established a rate to pay for it. But I can tell you that at UCLA, and I'm sure UCSF, we're working with insurance companies and we're working with patients to get coverage. But for the most part right now, patients still have to pay up front for it and then get reimbursed for it when hopefully Medicare starts paying for it. But hopefully within the next 6 months, it will actually be not only approved but paid for.
So I know you and your group have published extensively on MRI for diagnosis and management. Do you think the PSMA PET could supplant MRI or be an adjunct to it?
So we just actually submitted a paper on this in men with higher risk cancers who we obtained a PSMA scan prior to surgery. And what we found is that perhaps they're adjunctive. PSMA cannot replace MRI. MRI is much better at localizing spatially where a tumor is within the prostate and provides really important information about the biology of those tumors as well. But PSMA may, in certain cases, prove adjunctive. There are cases we've seen where the MRI is negative, but the PSMA scan is positive in the prostate. Vice versa, cases where the MRI is positive and PSMA is negative. We did see for sure in this publication that tumors that were thought to be perhaps localized to one side of the prostate, sometimes PSMA helped to see that the true extent was greater, because one of the deficiencies we published on a lot about MRI is that it can underestimate the size of a tumor. And given the current interest in focal treatments or ablative therapies for prostate cancer, the ability to localize the cancer in the prostate becomes paramount.
Well, that's kind of a nice segue for our next question. Now, looking ahead, and what do you see as some of the potential future applications of this agent, in addition to its current indications with initial staging and localization of recurrence?
So I think it's going to be useful for more advanced disease. Right now, we really don't have good ways to monitor tumor response in more advanced disease, particularly because tumors can be very heterogeneous and different tumors may respond in the body differently to chemotherapy or other agents. So I think it's being explored much more now in patients with advanced disease to monitor responses to therapy, to monitor responses to hormone therapy, et cetera, et cetera. So I think we're going to use this tracer literally across the entire continuum of prostate cancer, from diagnosis all the way to the end of the disease. Then there's some really exciting things going on, both internationally and also kind of locally. So internationally, what's really exciting is this concept of theranostics, which is taking the small molecule that binds to PSMA, binds to prostate cancer, and not just labeling it with an isotope that can be seen by PET scan or detected by PET, but one that is actually therapeutic. So an isotope that actually will kill cancer cells. And right now, there are two types of radio tracers that are being used for therapy that have been hooked up to these PSMA ligands. One is lutetium, which is a beta emitter and has significant anti-cancer activity. And the other is our so-called alpha emitters, like radium, which we currently use in prostate cancer that's metastasized to the bone. So the PSMA lutetium tracer or theranostic has actually completed phase 3 trials. I certainly don't know the data, but the preliminary data that's been published from phase 2 trials in the US and in Australia and in Europe have shown pretty dramatic responses to this theranostic. I think we need to learn much more about it. We need to learn how much durable these responses are, who responds and who doesn't respond, and why some patients become resistant to these treatments. But I think it's going to be a really important new treatment in our total armamentarium, which is growing for treatment of prostate cancer. Then I think the final area that I think is going to be really exciting for us, particularly as urologists who are surgeons, is right now we're very limited when we're in the operating room, whether we use a robot or whether we use our hands we can't really see cancer. And even if a patient has a cancer that we can see by PSMA in a lymph node, we don't really have the ability to see it in the operating room and make sure that we got it. So there are two approaches that we and others are exploring, one of which has already been used in Europe, in Germany in particular, but we will be starting here hopefully in the next month or two, which is exploring taking the same PSMA probe and hooking it up to technetium and then using a handheld probe in the operating room or a robotically held probe to detect the signal emitted by the tracer when it binds to the tumor. So the idea is that we'll be able to localize the tumor, particularly in lymph nodes, but perhaps around the margins of the prostate so that we can do better surgery. But the ultimate, I think, way that we'll do this is by fluorescence, using a probe, the same probe or a different probe hooked up to a fluorescent or optical tracer that we can actually visually see. So that the idea is that you'll be able to see the fluorescence of the cancer to know whether or not you resected everything or not. So far, we've done in my own lab lots of preclinical work using antibodies against PSMA and also another one called PSEA. It's a different cell surface protein. And at least in mice, it's very exciting. So I'm looking forward to over the next few years or so to really take this into patients. But I think that the ability to see tumors in real time for different cancers as well as prostate cancer will revolutionize surgery.
Well, as a robotic surgeon myself for prostate cancer, this is very exciting and look forward to kind of seeing as it comes down the pike for sure.
Yeah, we already have fluorescent camera. We have cameras capable of seeing fluorescence in the near infrared spectrum. So these probes will be useful with those cameras.
Well, I certainly applaud you and your group for all that you have done to advance the field of urology in utilizing new and innovative imaging modalities in helping patients address difficult management decisions. Dr. Reiter, any final thoughts today for our listeners?
Well, I think we're in an exciting time in the management of this disease. We've now got better tools to locate disease. One thing we didn't talk about is using PSMA in the setting of men who have limited metastasis to other sites in their body, so-called oligometastatic disease. And again, the idea is if you can see it, you might actually be able to eradicate it. So radiation therapists, for instance, are using radiation targeted to PSMA detected sites to try to actually increase and improve the responses to treatment. So I think that the simple concept of seeing is believing is going to increasingly hold true and has been over the last decade and a half. So it's exciting to see.
Well, I know that many of our listeners who might be candidates for PSMA PET imaging will be interested in finding out how they may go about receiving this test, as well as one might expect in undergoing the testing. I know we're running out of time here today on the podcast, but Dr. Reiter will be sticking around for some bonus discussion for the upcoming Prostate Health Academy. We still aim to open this yet in 2021. So for those that are interested in listening to the bonus content, make sure you don't miss it. You can sign up to be included on our list at www.prostatehealthacademy.com. Well, Dr. Reiter, it was a true pleasure having you on the show today. The knowledge that you have shared was very valuable. We really appreciate you taking the time to chat with us here on the Prostate Health Podcast. So thanks again.
You're very welcome. My pleasure.
Thank you again for listening to the Prostate Health Podcast. We would love to have you join our podcast Facebook group at www.facebook.com/groups/prostate health podcast, or just use the Facebook group search function and search for the Prostate Health Podcast and ask to join. We'll see you at the next episode.